Hello and welcome to the Uprising Show. And today I actually have my very first guest from Canada, Michael Miller, who is CEO of Verto. So, Michael, please take a few minutes to introduce yourself to our audience in your own words.
Yeah. Hi, Vivek. Thanks for having me on your show. Yeah. Quick background on myself. I'm actually a technical founder, so my background is computer science. I think I'm primarily a nerd, and then secondarily, I got interested in focusing on healthcare. And so I was born in that era where I started seeing computers really revolutionize how we did work, right? So I was brought up in the era when computers were really starting to change how people worked. And so I got really excited. And the more I thought about it, I realized I went to school. I had my hiccups, a few bumps on the way, but I finally got my comp sci degree. And when I graduated, I lived in this town called Edmonton. It's a university town. And really, it's in Alberta, and really most of the jobs were predominantly in resources, so like oil or natural resources. And so I said, okay, what do you want to do? What do you want to do with your skill in computer? And that's when I decided on healthcare or education. And in Canada, the hub for that is kind of Toronto. And so that's how I decided not only to move to Toronto, but also that I want to focus on healthcare, and I haven't looked back. And I've jumped between hospitals, worked in a few private companies as a e-health strategy lead for the largest payer here in Canada, and that's when I realized that we just manage data so poorly in healthcare. Like we say that it's a huge asset, but we don't treat it like a huge asset. And that's where I got the idea for kind of creating the digital twin company, which is Verto.
Fantastic. So, you touched a little bit about your upbringing there, but were you an entrepreneurial as a kid? Was it what were you selling lemonade stands, stuff like that, or is either of your parents an entrepreneur?
Yeah, that's a great question. Both of my parents are actually immigrants. My mother came from Japan. My dad came from Ireland. My dad was a teacher, and my mom was a stay-at-home mom. So I didn't have direct proximity to entrepreneurial forces. Um, that being said, I love solving problems and helping, and I think that I really the funny thing is I didn't crave becoming a CEO or an entrepreneur. I just wanted to keep on solving harder and harder problems. And I think that at some point, if you really want to solve the hardest problems, it does drag you towards leadership. And that's but I don't think that I had a direct parental effect, but I did have this insatiable want to solve a harder and harder problem every single day. So that's what drove me
Interesting.
here.
I always, and again, I'm also an immigrant, and I'm actually the first one from my family to first to Europe and then to US. And I come from pretty much like a service class background, very safe. Security is the first thing, and I
Yeah.
personally struggle with a lot of time. Just like entrepreneurship looks like you have to like prepare your mind a lot when you're coming from that background. Like, can I do it right? And like, how do you make sure like give up the salary and security and go into this route? So for you, was it like because your parents came from different countries, and they were kind of service jobs, so was it like difficult leap for you mentally? Like, how did you like? What was that made you like? Okay, I'm prepared to go into this route now. How were the struggles? Talk to me a little bit about that.
I think it's a great point. I think if you logically think about it, there's no logical sequence of steps that will thrust you into entrepreneurship, because at some point you got to do something stupid before you become an entrepreneur, right? So my stupid thing was walking away from a six-figure salary to be able to start Verto. But I think that what drove me to that was um, ultimately that I had confidence in the idea, and I kept on, like, again, it's all about problem solving. I kept on checking. I'm like, hey, is someone solving this problem? And the funny thing is, I actually didn't want to create my own company. I just wanted to work in a great company that was solving hard healthcare problems the right way, right? There's a lot of digital health companies that solve a problem, but they don't solve it in a way that's sustainable. And so I kept on seeking. I kept on jumping and asking, and I inquired and I tested and asked people questions about different companies I heard about. And I just never found one that had this thesis that I was looking for, that was trying to attack data at its fundamental level. And so I think it was more of regretfully, I said, well, if I can't find one, I guess I'll just create one. And the person who pushed me over the edge on that one was actually my wife, because she's like, you keep on thinking about it, you keep on talking about it, just do it. And so I think it was 6 months before I personally decided that she was trying to kick me and just say, just do it. It's going to annoy you if you don't try it once. And then finally decided to take the plunge May 2017. So
Wonderful. What's your wife's name?
her name's Maheen.
Okay, so
Maheen.
we want to give shout out to her
It's
here.
Maheen, yeah.
Because of her, this company exists, and she pushed you into this. So certainly, we are thankful to her so that this company exists. And I'm actually really fan of the problem that you're solving. I've been in health tech for over a decade, and like you said, we've been singing this song for a long time about interoperability, and yeah, there we will solve this problem, and we are far from it, to be honest. and and it kind of sucks, but that's why we need people like you building companies like this. So talk to me, the moment or insight that led to the creation of Verto, and what specific problem does Verto solve today, and how is it different from existing solutions?
Yeah, that's a great question. So the insight actually came when I was the e-health strategy lead at that large payer. In Canada, the money all flows from a single payer towards providers. And so when you work in the ministry, you kind of see how these large enterprise digital health contracts are formed. And what I kept on noticing was a pattern where there would be a problem. We'd say that we need some digital health or technology to assist with it. We'd find a vendor to assist with that problem. And then once they solve that problem, the vendor would cement, like they would cement themselves around the problem, so that if you wanted to try doing some other type of innovation, the first thing is they cemented. So they weren't really focusing on an innovation. They really just took that one thing that you told them to do and did it very well. So you've got like electronic medical record vendors to do EMRs really well. But then when you're talking about patient experience, you're like, oh no, we don't do that. And they don't have to do that because they understand that the pain of moving them out is just so high that most providers will just deal with the fact that they only do that one thing really well. And at the same time, they knew how valuable the data that the providers are entering in, right? And so this really, every single person who worked in digital health knew that that data that a physician or a nurse or an assistant or any type of clinician was entering in was gold. It was gold. It completely was the legal record for everything else that you did. And yet I didn't see APIs. I didn't see this communication. I didn't see a want to share the data. And the reason why is they knew how valuable it was. And that's when I realized there are no market incentives for interoperability. There are none. It's one of those examples where a free market will create harder and harder ways for data to be exchanged. And also where the people who house the most important data will play a role as the ones who determine who they want to work with, right? So they will keep on feeding the ones that they don't feel are threatening to them. And when I saw that pattern, I was like, okay, well, how do you fix that? And there's no real, from the payer perspective, there was no real way to fix it. But what I did realize is that one way or another, all these health systems have to communicate with other people. EMRs have to communicate with diagnostic imaging systems. They have to communicate with PAC systems. They have to communicate with medication administration records. So no matter what, because healthcare is all about exchanging and sharing information to get to the best diagnosis and then to deliver the best treatment. And so either way, at some point, they're going to have to transfer information between either people. And that's when I realized, well, instead of asking them for the data, why don't we just listen to the data when it's transferred between systems? And when I listened to the data, so the HL7 V2 feeds or the data exports that were coming out or the feeds, I realized that you could start creating a snapshot around a patient. You could start understanding the data and forming it. And so the funny thing is, 2017, my whole theory was listening to data in motion to create a snapshot of the patient. I didn't even know that that's what a digital twin was, right?
Hmm.
So I think it was around about 2020 when I realized, oh my goodness, if you take all aspects of the data and the time and the location, and you put it together to create a story around the patient, you're actually creating a digital twin of the patient. And that's what brought me to there. And so really my aha moment was that data in motion is actually where the promise for interoperability was, not data at rest. And so I kind of obsessed over that. I tested out a few things and I realized you could create a very accurate snapshot of the patient just by passively listening to these broadcast feeds or these feeds, the transfer of data in healthcare. And that's when I decided to kind of create a company. Of course, it's a little bit more complicated than that, but that was a aha moment.
And who are the customers to whom you sell your solutions to?
Yeah, so primary customers in the very beginning was very difficult because I need to listen to data in motion. The only places I have data in motion are large hospital systems, right?
Yeah.
So we started in acute care, but what I started realizing is that there were ways where I don't. We started selling to acute care, so we focused on like automation by listening to data in motion. But then what I realized is we could also tap into primary care, especially EMRs, and make the data go into motion. And so that's where we've used, I'll talk a little bit more later about how we used AI to create data streams from longitudinal data. And that's how we're able to go back inside the community in primary care and post acute to create streams of data to help better inform the digital twin.
So is it still healthcare systems, or you have gone into payers and provider side as well?
Yeah. So we started in provider side. When you think about really digital twins, we're focusing on using them for population health or value-based care. Value-based care now goes into the payer domain as well. So you've got
Mhm.
ACOs and clinically integrated networks. Both of them need to work in the space between it. So they need both data sets. But it's actually strange to see how much of value-based care is powered almost exclusively by payer data. And so one of the things that we're able to do is, thinking about HIPAA, thinking about how we disclose and share information from a provider side to make value-based care more effective. That's something people are very open to doing and something that we're able to do with the digital twin.
Interesting. Yeah. I mean, as of now, I mean, the knowledge or the people whom I've spoken in value-based care, it is primarily driven by payers, and there is this push to make it more value-based care payments and reimbursements, but it's very limited still. Like, it hasn't touched, for example, the home care world, in which it should, because the caregivers don't make money, and that's why we have shortage, right? Like, that's kind of what I see the problem as. But it started to happen in health system and provider side, and that's interesting to see as a trend. And But it's interesting the part that you said, like, how do you give them that information by making sure not giving the information that you shouldn't be giving. So and that creates complexity, right? And it's like so complex to, like, how do you achieve that, right? So um my follow-up question is to more complexity. Data is complex, especially in healthcare. So, are you currently integrating with like? Are you have like a batch of EHR systems that you have integrated, and also more like you're also serving clients in the US market right now, or
Yeah,
are you planning to?
yeah.
And how many EHRs does Verto integrate today?
Yeah, so that's a great question. So we started in acute care, so we integrate with almost all the major acute care EMRs, so Allscripts, Cerner, Quadramed, Epic, Meditech. Because we use HL7 V2 feeds in the way that they exchange data, we can go in and rapidly integrate it with it. Recently, we've been doing bidirectional integration with Epic, Cerner, as well as Meditech Expanse. And that's where we started. But in the last 2 years, we've been focusing aggressively on primary care and specialty care. So integrating with Athena Health, next gen systems, where we're looking to do more home care products as well. The reason why is because if we're doing value based care, the best data for how to manage that actually doesn't exist in the acute care environment. It's in the primary post acute space. And so, there's another fairly successful company called PointClickCare here in Toronto. They have a great data set. Um, we've integrated with them for US partners before, and we're looking to do that going forward. But the goal here is, well, every single project that we go into, the way that we also say is if we haven't integrated and the vendor comes to the table, that usually we can have a rudimentary or foundational digital twin integration within a month or two after talking to these people. And we can have a more robust clinical integration within 6 to 9 months. And so the foundational one is really important because it's enough in understanding like physician attribution, services. So you're able to understand key aspects of a patient enough to automate large aspects of value-based or case management that ACOs and clinically integrated networks usually have to deal with.
Interesting. So, and I've been part of few companies where we try to integrate with this EHR companies, and API is one side, but then there is bureaucracy of like keeping the system closed and selectively picking partners. And like you were saying, right? Like, so did you face similar challenges where it was like extremely hard to get a buy-in from them? And even if you get them, then they come up with this, deals where like 30% of the deals that you get, you got to give us the revenue gen, all that you're suffering through the same problems.
Yeah, and that's why it was funny. It was a problem I knew about before I started Verto, and that's why the first thing that we did was we created an AI ingestion patent. And so what we used, and this is actually, this is 2018, so before AI was even cool. Actually, AI has always been cool, but after LLMs, it got kind of generative AI got nuts. But the whole thing is that we used this AI ingestion to listen to existing streams. So what we can do is go to customers and say, rather than creating a net new integration with your EMR, give me the whole scope of integrations that you already support. And so what we were able to do is tap into existing APIs, tap into existing feeds of data, and show the customer back what their data profile looks like. And I would say 80% of our clients, it was good enough. We didn't have to do any net new integration in order to support the activities that we needed to do. And for the remaining 20%, we still were able to get to a go live of some site, and going to a vendor, EMR vendor, and saying, well, we already have this data, but we're missing the appointment data or we're missing medication is a much different conversation than, hi, I'm a new vendor and I want to access the EMR.
Yeah. All right. Well, that's good. That worked in your favor, kind of. So that's great. And let's talk about AI now. So the way I think about AI and it is that it makes systems intelligent by feeding gazillions of data sets, and your business is data business. So how do you see its impact on your tech currently? And if you also can talk about the couple of things that you're most excited about that you've used AI in helping you in transforming your tech.
Yeah, for sure. Um, so one thing I failed to mention earlier on is I actually teach health informatics at University of Toronto. I've been doing that for 7, 8 years, I think now. And so I kind of saw this AI phenomenon change from curiosity in the healthcare space to an obsession. Like now it's a full obsession. Like you're not cool in digital health unless you're doing at least 3 Gen AI projects, right? Are people actually using it to transform healthcare? I don't know, but it has a huge impact. And one of the reasons why it's so powerful is when you talk about AI, when you talk about technology pre AI, there was high barriers of entry. You needed to understand data, API, technologies, and structures. But as AI gains more foothold and everything, you talk about it less as in technology and more about activities or more about human behavior, right? So if you want to talk about like the first patent that we created, I actually created from looking at what I did repeatedly. I was looking at something like the first integration I had to do. I remember I went to a hospital and I said, "Hey, I've got this cancer rounds tool. I want to integrate with your HL7V2." And they're like, "Sure, we'll set you up 6 to 8 months from now to do an integration." And I'm like, "I can't do that. I need it done in 3 weeks." And they just laughed at me. They just laughed. And I said, "How about this? Why don't you just send me the raw feed? I don't need an integration specialist." And for some reason, I had enough power in my executive stakeholder that they said yes. So this hospital sent me 2 million messages a day, right? Just raw sent it to my system. First thing that happened, my system went instantly down. It instantly went down. It was a DDoS. But then I realized if I can look at all the data, I can see patterns. So I just looked at every one of the messages and I compared how they changed and what was the same. I found name, patient ID, encounter ID. I started finding medications. I found admitting doctor, insurance codes, and I just reverse engineered it. And all I did for an AI patent was use the same process of elimination approach and said, why can't AI do that? Why can't I do that statistically rather than in my brain? So the interesting thing that excites me the most about AI is if you have a person who is logically trying to do a complex data problem and you watch exactly the steps that they do to be able to solve a complex data problem, intrinsically that's AI-able. You can train an AI to do those same steps. And so the exciting thing is that to create a digital twin, we have to do many different types of backflips with data. I need to hire some really intelligent people. But what we've done is we've mapped that entire journey of that data, exploratory data analysis and data cleansing space. And we've analyzed everything and we said, what aspect of this is AI-able or not? And the crazy thing is the entire pipeline actually has a potential of being AI'd, right? And so that's the thing. I'm starting to use AI as a verb, right? It's like it's not a technology, but can you take that process and make it into a problem set that can be solved by large language models or a mixture of experts or a mixture of different approaches? And when we really scrutinize our entire data pipeline, the answer is yes, which means that entire process that we do to consume millions and hundreds of millions of patient records over many years that I thought would just require a larger and larger data team could actually be an entire product. And so the weird thing now is what amount of that team do you dedicate towards creating a product and what part of that team do you dedicate to providing a service? And so that's a real kind of experiment that's going on right now. But it's exciting that, every 6 months, there was an entire thing that took me 2 or 3 people that now is an algorithm that we run against the data set that was just prepared in a certain way. And so that to me is the most exciting thing. And our journey on this all started with me being annoyed at having to do or find patterns in integration with these HL7V2 feeds. And then really to the point where we're now sending narrative text and free text to this ingestion pipeline. And it's actually pulling insights and information outside of it. So I'm excited. I always like having a part of our product where I don't know where it's going to end. And the exciting part is that this data ingestion and normalization is a huge never-ending journey of opportunity for us, right?
Yeah, I mean, and would you? I mean, just the outside of your product, where in healthcare? I mean, data is obviously a big part where AI is going to play biggest role, and I also feel like there's a lot of diagnostics, right? Like there's a lot of coming up with what's reading the data and finding the pattern, giving the diagnosis based on that. That's going to be huge. What other areas you think is going to have a big impact?
Oh, that's a huge point. Sorry, I have recency bias. I just got excited by my data team talking about that pipeline. So, but no, the funny thing is, I think AI will fundamentally transform healthcare. Like, just let's just be clear. Everyone thinks Healthcare is, anyone who thinks that healthcare is not an information business doesn't understand healthcare. Healthcare is all about information. If you have the right information, then you get the right diagnosis. If you know the right diagnosis, then it's just a matter of administering the treatment, right? So it's a DX kind of like game, uh, and that's healthcare. And so getting to a diagnosis ultimately means knowing the entire wealth of healthcare data, right? So this is a crazy stat that I just heard the other day, which is that our entire knowledge base of healthcare is doubling every 76 days now. So
76 days.
basically, 76 days, right? So every 76 days. And it's because you have to think about it, right? There's procedural generation. There's now AI that's creating new molecular and diagnostic interactions. And so healthcare has infinite permutations when you think about it, right? And one of the problems in healthcare is as we live longer, we have more comorbidities, right? So more people have not only have diabetes, but they have COPD, they have CHF, they have different chronic diseases. How do you best treat people with those comorbidities? Well, there's research coming out on that. And is it reasonable for a human being to process that 76 days worth of doubling information to give the best possible recommendation to a patient? I don't think it's possible as a human anymore. And so, at a minimum, we need to think tool assisted diagnoses. But if you really think about it in the future, if health data keeps on doubling even faster over time, then we're going to have to think about AI approaches towards it. And so, AI being injected into the diagnostic processes is just a matter of time. It's just a matter of time before that happens. And so, really, what I saw was that what I see though is it's not about AI going in that's going to be the big trouble. The trouble is how do you manage risk around AI? Like how do you ensure an AI algorithm that diagnoses something, right? So, right, when a doctor diagnoses and they diagnose incorrectly, they have a malpractice insurance, right? And then you stand in front of the jury. The doctor's like, "I need 1,000 patients. I did the best I could," and they're like, "Okay, fine, you did bad, but here's the settlement." And it's still not that cheap. Imagine an algorithm going to court, and 100 people say your diagnosis got it wrong and you profited off of the wrong diagnosis. That's $1 billion lawsuit. So how do you manage risk with AI diagnosis in the future? That's going to be the big challenge. And so I think that everyone can let your imagination go wild. There are really no bad ideas for what AI can do in healthcare. But what can AI do reasonably while managing risk in the current ecosystem in healthcare? That's the question that we have to answer to understand what the ultimate impact of AI is going to be in health.
I fear, and I've seen this movie in healthcare earlier as well. Like whenever we talk about data, it sounds exciting. People want to tackle a lot of problems, and then what happens is somewhere in this, the pipe breaks, data pipe breaks, and then it creates a ton of administrative work for everyone, including providers. And instead of productivity gain, it becomes like productivity pain, and this happens a lot, right? So I'm cautious with that because not all companies are going to, supposedly they claim they are solving this problem through AI, but I don't think they are all going to be foolproof solutions. There will be problems coming in there, right? So
Oh,
what's your take on that? How can be like cautious but still still keep the excitement around it? How do you feel
yeah.
about that?
I think primary care physicians were terrified when they heard the term generative AI, right? You're telling me AI can create reports and discharge summaries. You're telling me that I need to now, like, that's just not fair. Human beings should not have to be uh, regulated to process AI output, right? That's insane. But what's even scarier is AI generated output being processed by AI, right? So it's going to get to the point where the communication medium isn't for humans. It's just, but you know what the funny thing is what do you call a generative AI output that talks to a generative AI input? Well, I call that an API, right?
Yeah.
So I mean, the whole thing is that the funny thing is that if it's kind of funny because the world's coming. The need of the market, the need of the patients and the providers is interoperability. But the manual world where vendors controlled the directive, where there wasn't there, was that there was control in that information flow. What I'm excited to see is I do think generative AI will create new ways, right? Because generative AI, or the new world of AI, acts more like a human and less like a technology, right? And so if humans can access clinical information, well, then there's a path for generative AI to access that information as well. And so what you're going to see is that the market forces, rather than the vendor forces, will actually win out at the end of the day. So I'm excited to see AI outputs because I think it will force AI inputs. And that's why I think is going to be interesting. But again, it all comes down to I hate being a broken record on this one, but it comes down to risk management. Everything that we do, the fact that we have a call that we certify physicians, the fact that there's a residency program that they do 4 years of like proof before they're able to practice, and then there's these different morbidity and mortality rounds. All these controls are based around managing humans. They're not designed to manage AI, so it will challenge the system in quite a way. And so I think, in the same the good reference, the similar reference I have is an industry that should have been disrupted 15 times over but never has is the real estate industry,
Mm.
right? And the reason why is because the interest groups have enough control about the industry dynamics that it won't be there. I do think healthcare has the same type of regulatory control from an interest groups and from because ultimately you can have the best diagnosis with AI, but the people who treat are going to be the human beings that come there. And so as long as that equation's there, I think that those controls will help us in regulating the speed at which AI gets pushed into healthcare.
Yeah, I'm optimistic in general. So I'm hoping everything goes in that. Like you said, the key point here is risk management. I think that's will be critical. And then of course, I do see like, physicians are traumatized with the tech they have had in the past, so they're reluctant, right? So even though it might work, there must be that level of building trust again, that this will work, right? So that's important, I think. All right, so let's talk about your journey a little bit here. So pivots are major part of any startups. So I'm sure your company has gone through a few pivots. Could you tell me about one or two pivots that was like super critical for your business and why?
Yeah, for sure. If you're in digital health, one of the most, I think every digital health company had to pivot in 2020 when the pandemic hit, right? Because unless you were Zoom or like a web conferencing company, then you had to rethink it. And so definitely the market forced us to pivot in 2020. Like we were working towards creating digital twin, towards creating this focus on chronic disease, and all that disappeared. And so we had to say, how do we take the technology that we have and adapt it into a use case that helps out in during the pandemic? We came up with two answers. The first one was using our digital twin to target people who were the most vulnerable to COVID, so that as vaccines rolled into Canada, we could give it to the people who needed it the most rather than just opening up to the public as a whole. That was one use case. And then the second use case was about lab process automation. And so we worked with multiple labs here in different jurisdictions to make it so that you could have a consumerized COVID test, but send it to any number of laboratories without needing to create custom interfaces for each one of them. So it was a huge pivot, and it's a pivot that we went into so effectively that we were actually profitable for 2 years in a row. And so, we founded in 2017 and 2019 and 2020 and 2021, we were profitable because we met the need. But it's always interesting becoming profitable on a market that is going to disappear in 2 years. And so to me, the interesting thing about that pivot was the knowledge as we went in that we'd have to go out as well. And so the timing was very difficult in understanding when is COVID actually over? Like, and the funny thing is, COVID's not over. COVID's all around the place. It's just we know how to deal with it. We brought it in, um, but at the same time, it was a societal sentiment when COVID was over. It wasn't like a medical reason why it was over. Because in the US, it was over a year before it was over in Canada. And that was not because COVID was acting differently. It was just because people just socially were like, I'm done. I have accepted the risk of COVID and I'm not going to let it affect my life. And just in Canada, that threshold was a little bit higher. And so it was interesting having to gauge that, straddling both markets on when do we pivot away? When do we market back to our population health solution? And I think the part that anyone in digital health was surprised about was, and not surprised at the same time, was after COVID, the health systems took a year to recover, right? Because health systems become profitable when they're predictable. And when they're not predictable, well, there was negative operating margins across the US in 2022, right? And so we're finally on the other side of that. So the funny thing about that pivot was that it was fun while it lasted, but knowing that we had to pivot back was the interesting part as well.
So would you say now those revenue streams have completely died after your this pivot, or you still have it
No,
somewhere?
there's some that I thought would totally die, but they pivoted. They themselves pivoted into creating online services and virtualizing what they did. Those customers stayed on, but I definitely think that in terms of the lab opportunity for some of them pivoted towards consumerized testing, but the ones who were running the COVID clinics, like their business model fell apart. So obviously our
Yeah.
clients walked away from that.
Okay. And now about your company currently. So how are you acquiring your customers today? What channels? And could you elaborate on the strategies that probably are working and those haven't worked?
Yeah, no, that's a great question. So the U.S. and Canadian markets are very different, and in Canada, you kind of have to get to a level of awareness just tacitly throughout the digital health community. We've achieved that, so people are aware of what we're doing, and so mostly it's just about um, thought leadership marketing as well as running webinars and talking to people about what our product does. But the Canadian market's pretty fixed. You can count. It's less than 1,000. Sorry, less than 100 people that can actually buy our solution. So it's a lot more focused. In the U.S. market, um, what we find is that people will move when there's a problem that they have that they think that you can solve. But and people are more willing to take risks. But the channel, initially we thought we'd use channels such as other technology partners who integrate, so like clinical document repositories, other integrators. That channel didn't work out because what we realized is that the people who are tasked with solving population health or value-based care don't sit in the IT department at all. They're completely in a different side, right? And so we've had to rethink the way that we go out. Our new strategy is using mid-level implementers as well as just meeting these ACOs and clinically integrated networks in their own environment. And also meeting them around regulatory changes, because one of the things that drives adoption and need is always a change in stars regulations or different type of value-based metrics. So you just have to be aware and in the conversation when those changes happen so that you're prepared to answer and meet them at that regulatory shift. And so it's been interesting. We're still trying to understand what our number one channel is, but right now, I would say it's primarily conferences and the mid-level implementers.
Got it. And what are the biggest challenges at the moment for you as a CEO?
Biggest challenge for me is we have a lot of, going back to the pivot discussion, we have a lot of reputation on our old product, virtual, like digital front doors, scheduling. And that's steady. We have a good client base. We have a good product in that area, but we want to develop the digital twin more, right? We want to have more clients. So what we find is clients buy us to solve a specific problem, but it's very rare to find a client who wants to engage in a true strategic partnership to push the agenda of your product. the exciting thing is we now have like around about 3 or 4 of those really strategic partners who are combining the power of the digital twin with our ability to orchestrate to really do these foundational changes to how their health system works. So it took us a while though. It took us like 2 or 3 years before we found that level of partner, right? Because we go to someone, they say, "Oh, I have this one area that I want to solve." We solved it, like, "Thank you," and then they walked away, right? Whereas a strategic partner is someone who actually understands what we're doing with the digital twin, that we've normalized that data. So now that we've done that hard work, we can automate interventions in chronic diseases. We can actually help them plan out where they're going to do these systems. Finding partners who know that was the hardest challenge because it's a new technology, right? And so
Right.
now that we have that, I'm really excited because there's. Have you heard of the concept of the Rogers adoption curve? Like
No.
the innovators, the early adopters, the
Yeah,
late
yeah.
early
Hmm.
majority, right?
Hmm.
Like finding innovators in healthcare is very hard. A lot of healthcare systems say that they're innovators, but they're just early majority, right? But
Yep.
for our technology, we truly needed to find those innovators to push it. And now we're creating the case studies and the uses for those early adopters and the early majority to actually absorb. And that's what's exciting because that's how you get to the growth curve, right?
Yeah, I think the I think you pointed this out just briefly there, that an ideal partner for you is who understand not just the scope of the use case they're starting with, but scope of the technology, and how once you are done with this phase or project, then what is the next they can pick up in their org to like use it. Like they use
Yeah,
that tech and implement it, and that's kind of where you're looking for those people to have that kind of at least understanding and vision of how they can utilize this technology in different areas and keep going after one after another different areas, right?
yeah.
So
And
it's
the
very
interesting
interesting.
model there is also convincing your team that you need to incentivize this behavior. It's rare. If it's rare, then like it's like an interesting thing. If you only think about use cases, well, then I'll charge you revenue. But if you're going to innovate and strategically partner with me, then it's in my incentive to let you go wild and actually make these new use cases. So once you find those people, it's about how do you grow with them in a way that's reasonable, but really incentivizes them to push the envelope. And so I like these
It's
kind of
uh,
models.
it's interesting also on the commercialization end. Like how do you price it? Like how are you pricing it? I'm sure this is a complex puzzle on your end. I bet it is. But tell me about it. Like how are you pricing it currently?
Literally that's what I was working on right before this, right? Because what I've realized is there's a way that you need to price it for early adopters, for the early majority, but you need to be smart about where you apply your discounts. So you should be consistent on how you price it. And our pricing model is generally based on per member per annum, as well as the number of automations, so the number of API calls, you could kind of say,
Mhm.
roughly. But when you find an innovator who's really pushing it, you want to remove those thresholds because the variableness of it will stop them from wanting to do new stuff inside it. Because every step that they take, they're having to pay for it. And when you're solving a use case, you can make the ROI calculation. I'm saving this amount of money, so it makes sense for me to spend 1/10 of it to move forward in that direction. But an innovator doesn't think like that. An innovator thinks about the technology. And so they're taking risk in the next step. They don't know if they'll save money. And so you have to be smart about how do you make sure that an innovator wants to take that next step without just becoming completely resource strapped supporting their guesses, right? And so it's an interesting dynamic, but I've been craving these innovators for so long. So that now I found the 2 or 3. My whole goal is how do I make them shine more, right? So
Yeah, yeah. That's also just like how the economic environment is, and we'll talk about that a little bit, like where you are in your fundraising currently, and what's your current traction. But in general, the word is if you have the customers, try to keep them, try to expand with them, and that's the best growth that you can have at this market, right? Like at least right now, right? So let's touch upon your current fundraising. Are you fundraising? What's your current traction?
yeah, so we're not fundraising right now. Well, the answer is you're always fundraising, but we're not looking to close around right now. I think for us, to your discussion, we're trying to see, we need a predictable channel. We need a consistent, predictable channel for sales into the new ACO market before there's a need for me to actually trigger the next route. Our traction right now, we're just under shy of the 5 million mark ARR, but we're quickly going to surpass that in the next 6 months. We're starting to get our larger clients. We had a lot of smaller kind of orchestration and scheduling clients before, and now we're moving to larger digital twin clients. As you solve population health, the ROI and the value that we provide is pretty obvious. But the interesting thing right now is that, to the earlier point, monetizing ARR growth will stop some of our early innovators from thinking of neat use cases for it. And so we've had to make a decision about, do we want that rapid ARR growth, or do we want to have more and more use cases out there to prove it? And the more and more I realize, the healthcare market is mostly formed by early and late majority buyers, not by innovators and early adopters. And so when you find an early adopter or an innovator, creating use cases that you can then research, do a proper like value ROI study on, and then going back to market is worth more than getting a little bit more of ARR out of it. And so really that's kind of where we're at on our reflection. But yeah, from a traction perspective, we want to see this go to market in the ACO space work out before we trigger the next fundraise.
Makes sense. And also, like, just on your point on, like, I have seen startups who've just built, gone deeper with one health system, and just that one route and one customer was enough to give them, make the case study for next 3 years, have them raise the next round. And after that, commercialization was also easier because the word got out, the case study went out. So there is a value in that, going deeper, and with the one or two clients where they're large enough to fund you for a few years, but get you to fine tune your products, offerings, and then you have more commercial aspects. Also, the word gets out, the case studies there, right? So that's always helpful. So looking ahead, where do you see Verto in 5 years? What's kind of the long-term plan, long-term goals for the company?
Yeah, that's I've just been thinking about this recently. So now that we have specific use cases coming out, you need a year for them to show, then you need another year for you to actually do the ROI and the case study. So at 2 years, we're going to have hundreds of different use cases that have specific ROI. And so the part that's really exciting about it is it took a while, even in Canada, for our true technology to be deployed. In 2 to 3 years, I wouldn't be surprised if we were deployed in more than half, if not more than 80% of the systems across Canada. And I do think that the value-based care is only going to increase. I know that we're at this weird tension where some payers, some systems are saying, oh, no more. It's the only sustainable model. Let's just be honest. You have to change behaviors to move to that. I think value-based care, it's one of those things that's affected also about politics. So we're going to keep an eye out on that, on how it goes through. But ultimately, for sustainable healthcare in the next 4 to 8 years, U.S. is going to have to embrace, Medicare Advantage, Medicare in a big way, and I do think that our system is going to be key for that. So if we can get to, 10% market share of people with digital twins optimizing, I'd be excited. But the hallmarks are there. It already is backbreaking work just to stay on top of value-based care at-risk payment systems. And so there is a need for technology. There is a need for the society to go there. So that's what I hope to see.
Great. All right, this has been great. I like to conclude the conversation asking a fun question.
Yeah.
And so the question is, tell us about a personal thing that you have told no one in your professional circles, but this is your chance to share with them. It could be anything that you feel is appropriate to share, of course. So just, yeah, tell us anything that you feel like no one knows, but this is your chance to tell them.
That's a hard question. There's a reason why my professional network doesn't know certain things. Okay, one that's right on the precipice of personal is a lot of people might not know, but when I was younger, I was enamored by computers, and one of the first things that I loved doing was playing computer games. And so I played computer games, but I'm extremely competitive to the point where I actually ran an esports team in Counter
Wow.
Strike. So we actually ended up getting 14th in North America. But the funny thing was, I learned a lot about management. It's like when people say, "Where do you, I don't have an MBA, I don't have anything. Where do you learn your management skills from?" I'm like, I actually learned most about management from managing teenagers on how to become better at esports. Because in that model, you don't pay them money, you don't have any direct control over them. Even getting them to show up after school to properly practice is like really hard. And so being able to drive performance out of that group really showed me the non direct levers of management. And it's interesting because I think that it's something that I always wanted in a job. And it's now something that I institute in our company, which is, you don't pay a salary to control a person. You pay a salary because they deserve a salary because they're sharing that time with you. But you incentivize people on top of them. Well, how you get someone excited to do something is completely different than what you have to do from an obligation perspective. And that mentality has helped me shape how I manage and how I want to create a company.
Great, great chair. Kind of like reminded me of I think a book I read or something on that lead without title, like
Yeah,
and also reminded me one of my managers in earlier days who's also my mentor, and he told me like one thing that like the true leadership is not about the title, it's about the influence, how you influence people make without making them feel like you're making them do things.
yeah.
So it's exactly in that line. So yeah, great. So where, Michael, people can find you, where can they hit you up?
Yeah, so you can hit me up. I'm pretty good at LinkedIn and getting back to people on LinkedIn. So just look me up. It's Michael Millar with an AR. Um, Other than that, just you can send me an email also, but probably LinkedIn's the best.
Great. And their website is Verto.health. Check them out. I'm really excited about anytime I see a good data company in healthcare. Again, towards my optimism. So this was a great conversation. Thank you for everyone who is listening to this episode. Thank you.